the physiological process that regulate the parturition and the onset of labor. The three theories describe the labor initiation. The first theory, the functional loss of pregnancy maintenance factors. Second is focus on the synthesis of factors that induce parturition. Third theory suggests mature fetus is the source of initial signal for parturition commencement. The various research support a model that draw from all the three things. Thus, labor onset represents the accumulation of series of biochemical changes in the uterus and the cervix. First, in the maternal fetal compartment, the uterus and cervical changes. The myometrial layer of the uterus is composed of bundle of smooth muscle cells surrounded by connective tissue. What is the difference from the skeletal and cardiac muscle? The smooth muscle cells is not terminally differentiated. That is present in the uterus, therefore is readily adaptable to environmental changes. If there is many stimuli that such as like mechanical stretch, inflammation, or endocrine or paracrine signal, that will modulate the transition of this smooth muscle cell into phenotype that will provide the growth and proliferation and secretion and contractility of the uterine smooth muscle cell. Additionally, several smooth muscle quality confer the advantage of uterine contraction efficiently and deliver the fetus. What are the additional benefit of the smooth muscle in uterus? The first, the degree of smooth muscle cell sucking and contraction compared to the striated muscle. Second, the force that can be exerted in this smooth muscle cell is in multiple direction compared to in the skeletal muscle where it is aligned along with the axis of the muscle fiber. Third, the thick and thin filament of smooth muscles are found in long and random bundle throughout the cells. This flexible management augment the sucking and force generating capacity. Last, greater the multi-directional force in the smooth muscle that will generate in the uterine fundus compared with that the lower segment. The more force is generated in the uterine fundus compared to the lower uterine segment helps to optimize the expulsive force vectors towards downward and deliver the fetus. Then lining the thick muscular uterine wall, the endometrium is transferred by pregnancy hormone that is called deciduum. What is deciduum? Due to the effect of the pregnancy hormone, the endometrium transfer into deciduum. Okay. The compass of stromal cell, maternal immune cells, the deciduum serves as the immunoregulatory function, suppress the inflammatory signal during the gestation. However, the end of pregnancy, deciduum transition to induce inflammatory signal and withdraw the active. At the end of pregnancy, what happens? The deciduum transition to induce an inflammatory signals and withdraw the active immunosuppression that contribute to parturition initiation. During pregnancy, the cervix has multiple functions. What are the function of the pregnancy cervix? First thing is the maintaining the epithelial barrier to protect the reproductive tract from the infection. Second, the sustaining cervical competence to prevent the preterm labor, cervical incompetency despite greater gravitational force as fetus grows. And third one is the extracellular matrix that allow progressively greater tissue compliance. In non-pregnant, the cervix is closed, firm. It consists similar to the nasal cartilage. By the end of the pregnancy, the cervix is easily distensible and its consistency is similar to the leaf of the oral cavity. The cervix has a high ratio of fibroblasts to smooth muscle cells. Another thing, the smooth muscles are made up to 50% of stromal cell at the internal loss, but this is the difference in the percentage of smooth muscle cell in the internal loss and the external loss. At internal loss, it is 50% stromal cell but only 10% at the external loss. Then placenta. What is the function of the placenta? Placenta provides the exchange of nutrient and waste between the mother and fetus. The placenta is a key source of steroid hormones and growth factor and other mediator that will maintain the pregnancy and potentially aid the transition to the parturition. The fetal membrane, that is amnion and chorion and adjacent decidua, serve as a physiologic, immunologic and metabolic shield to protect against ultimately parturition initiation. What is the function? Amnion is a fetal membrane that is completely avascular tissue. It is highly resistant. Because of amnion is a thick membrane, it is resistant to penetration by leukocyte and microorganism. And this, it also causes, it acts as the amnion acts as selective filter barrier to prevent fetus particulate bound lung and skin secretion from reaching the maternal compartment into the maternal compartment. In this manner, what happens? The amniotic fluid constitutes prematurely accelerated decidual and myometrial activation or could promote adverse event such as amniotic fluid embolism. That will prevent the amniotic fluid embolism because of the thick membrane that is prevent as a barrier that will prevent the passes of secretion from the secretion like fetal particulate bound like long hair, skin, lanugo hair, all this skin secretion from the fetal to maternal compartment to prevent amniotic fluid embolism. Okay. Amnion, this is the amniotic fluid. This is amniotic fluid. This is amniotic epithelium. This is the amnion chorion mesenchyma. Okay. This is decidual phytoplast. This figure, what is this signify? The amnion, what happened in the amnion synthesizes the prostaglandin, and in late in pregnancy, this synthesis is augmented by increased phospholipase A2 and prostaglandin H synthase. There is type 2 PGHS2 activity. The transport of prostaglandin from the amnion to the maternal tissue is limited by the expression of the inactivating enzyme, that is the prostaglandin dehydrogenase. What happened? This amnion synthesizes the prostaglandin, but this prostaglandin is unable to cross the prostaglandin is metabolized by prostaglandin dehydrogenase. So the prostaglandin cannot reach to the maternal compartment, and that prevent the premature activation of the contraction that led to preterm labor. During labor, this what happened during labor? This PGDH activity, that dehydrogenase activity, that is limit the prostaglandin E2 metabolism, that will metabolize the prostaglandin all the prostaglandin before labor. But in during labor, the prostaglandin dehydrogenase activity is decline, and that will lead to amnion derived prostaglandin can influence the membrane rupture and uterine contractility. The role of decidual activation in fracturation is unclear, but they may suspect that local progesterone metabolism, higher prostaglandin receptor concentrations, thus enhancing the uterine prostaglandin action and cytokine production in the residue. The chorion is primarily, what is the function of chorion? Chorion primarily protective tissue layer that provide immunological acceptance. It is also enriched with enzyme that inactivate uterotonin, which are agents stimulate contraction, inactivate enzyme like prostaglandin dehydrogenase oxygen. These are the inactivating enzyme that is present in the chorion that will prevent the prostaglandin, that will metabolize the prostaglandin like prostaglandin dehydrogenase, metabolize the oxytocin, oxytocinase and encapsulinase that metabolize the encapsulin. So that all these things are protect early initiation of labor before term. Then what is the function of sex steroid hormone? In many cases, sex steroid is clear. Estrogen promote and progesterone inhibit leading to the fracture. This is other stresses, but the removal of progesterone, that is progesterone, will directly progression fracture. These things are in the not in human species. In addition to providing progesterone to some species, will delay fracturation, have declined mitochondrial activity. But in human, these are all these things are in the other species. But in human, however, both estrogen and progesterone component of a broader molecular system that maintain uterine coherence. Another thing is increased progesterone to estrogen ratio in the maintenance of pregnancy. If it is decline in this ratio, that leads to parturition initiation. Suppose you are administering the progesterone antagonist like mifepristone RU4086 onapristone will promote some all key feature of parturition, cervical ripening, greater cervical distensibility, augment uterine sensitivity to uterotonic. Both progesterone and estrogen bind to nuclear receptor. Progesterone receptor A and B and estrogen receptor A and B. What is the role of prostaglandin? Prostaglandin is a lipid molecule that is varied with hormone-like action. In fracturation, they play a prominent role in myometrial contractility, relaxation, inflammation. There is prostaglandin interacts with the G protein coupled receptor, which expressed in the myometrium and the cervix. The major synthetic pathway is synthesis from the arachidonic acid by the help of the enzyme phospholipase A2 or C. There is two. This is the pathway. Arachidonic acid in the phospholipid store that is converted by the phospholipase A2 or phospholipase enzyme converted to arachidonic acid. This arachidonic acid, with the help of COX-1 and COX-2, that is PGHS1 and PGHS2, it is converted into PGH2, and then PG isomerase is converted to PGE2, PGF2 alpha and PGI2, and these things are metabolized. If it is not in labor, not in term, these three things, the prostaglandin E2, F2 alpha and I2, that will be metabolized by prostaglandin dehydrogenase, that is secreted by the chorion and amnion, that is inactivate the prostaglandin metabolite and prevent the preterm labor. Through the prostaglandin isomerase is converted to the active prostaglandin. Okay, the expression of this PGDH during pregnancy in the uterus and cervix provide an important ability to rapidly inactivate the prostaglandin. Thus, the myometrial response to prostaglandin stems from a balance between prostaglandin synthesis versus metabolism. Progesterone contribute to the relaxation stage of pregnancy, myopia control after pregnancy. In addition to myopia, amnion synthesizes several biopeptides like cause myopia relaxation, contraction. Amnion is the likely major source of amniotic fluid questioning their role in the activate cascade. Phase 1. There is uterine quiescence, cervical softening. What is phase 1? There is four phase of initiation of parturition. These four phases are initial parturition phases, not the stages of labor. Stages of labor is 3 stages, that is different. And phase of parturition is 4. That is phase 1 is quiescence phase or prelude to parturition, before parturition. Phase 2 activation or preparation for labor. Phase 3 stimulation or process of labor. Phase 4 is involution after delivery, parturient recovery. This is the what happened in phase 1, that is phase of quiescence. In this stage, quiescence, uterus in quiescence stage before the parturition, contractility, on responsiveness, cervical softening, only this thing, cervical softening in the phase 1. Then phase 2, that is the activation phase. That is the, you have to prepare the preparation for labor now. How you prepare uterine preparedness for labor, like cervical ripening. In phase 3, process of labor, already it is started, means uterine contraction is started, cervical dilatation started, fetal and placental expulsion. Then all the 3 stages of labor in phase 3, stimulation, process of labor, all these 3 are in this phase. Okay. Phase 4, involution, that is parturient recovery, prelude, preparation, process and parturient. Prelude, preparation, process and parturient, uterine involution, cervical repair, breastfeeding, fertility restore. Okay. These all 4 phases of parturition. In phase 1, what is the phase 1? Uterine quiescence on cervical softening. Uterine quiescence parturition can be actually divided into 4 overlapping phases that correspond to major physiological transition of the myometrial cervix during pregnancy. First phase, prelude phase, then is preparation phase, the advanced process itself, and the recovery phase. Importantly, the phase of parturition should not be confused with the clinical stage of labor. The first, second, and third stage make up phase 3 of parturition. All phase 3, the process of labor, started initiation, stimulation of labor, that is all in phase 3. All the 3 stages in phase 3 of parturition. Beginning of the event before implantation, effective period myometrial quiescence. The phase 1 normally consists, what is the phase 1? Phase 1 consists of 95% of total duration of pregnancy, and it is characterized by uterine smooth muscle tranquility with maintenance of cervical structural integrity by the neural, endocrine, paracrine and autocrine implemented according to all these systems and make the uterine on responsiveness and quiescence stage. In phase 1, this the major cytoplasm, the key factor that regulate the process of each phase of the maturation. That is in phase 1, that what are the things that will protect, maintain the uterine quiescence, that is prostacyclin, nitric oxide, HCG, and corticotropin releasing hormone, caspase 3, period of immunocompetence, progesterone and prostaglandin dehydration that will metabolize all the prostaglandin I2, F2, alpha, E2. Then phase 2, that is the preparation before labor. What are the things to prepare? What are the things it will prepare? First, because of uterine stage, that will stimulate the uterine stage, that will gap junction receptor, fetal signal like surfactant protein A, fetal activating factor, corticotropin releasing hormone secreted from the hypothalamus of fetus brain, then fetal membrane senescence, prostaglandin, cortisol, progesterone, non-classical erythritol, estrogen and relaxin, and hyaluron in the phase 2. All the preparation phase. Then phase 3, that is the process or stimulation. Already it has started. Then what are the things that will stimulate the labor? Prostaglandin, oxytocin, corticotropin releasing hormone, inflammatory cell activation, estrogen, relaxing. In the last phase, that is the phase of recovery phase, that is the recovery phase or puerperal phase, the oxytocin, inflammatory cell activation. Okay, what happened during phase 1? The uterus must initiate extensive changes in its size. What happened in phase 1? Phase 1 is the prelude phase or prelude phase or quiescence phase. In this stage, in this phase 1, initiate extension in size and vascularity. What happened in the phase 1? The fetus has to grow, so the uterus has to change in its size and increase in the vascularity to accompany the fetus growth. Okay, concurrently the myometrial cell undergo phenotype modification to a non-contractile state, and a uterine muscle remain unresponsive to natural stimuli. All of this okay, don't normally because cervical dilation. Therefore, some this contraction, although this unless we continue until near the end of pregnancy, some low intensity myometrial contraction are felt during this quiescence phase. That is called as Braxton Hicks contraction or false labor that don't normally cause a cervical dilatation. They are common toward the end of the pregnancy, especially in multiparous. The questions phase 1 likely stems from the what are the factor action of estrogen, progesterone by intercellular receptor, myometal cell, plasma membrane receptor mediated increased cyclic adenyl phosphate, and generation of CGMP and other system including the myometal cell ion channel. First one is a myometal relaxation and contraction. How it will maintain the relaxation and contraction? What are the factors? The balance between the myometal relaxation controlled by steroid and peptide hormone transcriptor regulation (PG). Questions is achieved by diminution of intercellular crosstalk of reduced intercellular calcium, ion channel regulation of cell membrane potential, activation of the stress unfolded protein, uterotonic degradation. Okay. In contrast, the contraction, these are the things that maintain the equations, that is the maintain the relaxation of the uterus. Past one is the diminished intercellular crosstalk and reduced intercellular calcium, ion channel regulation of cell membrane potential, activation of the stress unfolded protein, response by the uterine endoplasmic reticulum, uterotonic degradation. These are the things that maintain the equation, that is maintain the uterine relaxation. What are the factors that maintain the uterine contractility? Enhance the interaction between the actin and myosin protein. First one, the heightened excitability of individual myometal cell, promote intercellular crosstalk and allow the synchronous contraction to develop by the help of calcium. Actin myosin interaction. Okay, you understand this thing? Okay, here the corticotropin releasing hormone or beta sympathomimetic or prostaglandin E2, that is through the G protein coupled receptor. What happens? The ATP is converted to cyclic AMP. The cyclic AMP activate the protein kinase A, and the protein kinase A. This is the smooth muscle that is in the relaxation phase. What are the mechanism? The corticotropin releasing hormone, beta sympathomimetic, prostaglandin E2 bind to the G protein coupled receptor, and that will convert the ATP to cyclic AMP. Cyclic AMP is converted the activate the protein kinase A. Now the protein kinase A it will be activate the phosphatase enzyme. Then the phosphatase enzyme is lead to dephosphorylation of the phosphomyosin light chain kinase 20. That will lead to dephosphorylation. Now it cannot bind to the myosin. Now the myosin head is inactivate, and it also make the actin filament. If it is in the globular state, like small globular state, it will not bind to the myosin complex, nor it lead to the relaxation. Same thing, opposite thing, that is the oxytocin, thrombin, prostaglandin F2 alpha that lead to contraction through the G alpha protein coupled receptor. The phosphoinositol now got diacylglycerin inositol phosphate 3, and that will activate that will stimulate the release of calcium from the sarcoplasmic reticulum, and from the increase the intercellular calcium from the outside cell membrane. The calcium now increase. The calcium may combine with the calcium calcium complex, and that will activate the myosin light chain kinase, and that will phosphorylate the myosin LC20 chain, and myosin LC20 become phosphorylate too. Now it is the myosin chain. Myosin is active. Myosin chain is active. Now actin also in the filamentous form, that will bind to the actin myosin complex, that lead to contraction. Okay. The logical uterine relaxation article prompted condition of lower contraction, calcium 2. In contrast is in that ferment contraction and calcium. PGF2 alpha, oxytocin bind the respective receptor during labor to open ligand gated, activate calcium channel, activation of this receptor, release calcium from the sarcoplasmic reticulum. Additionally, greater localization non-selective calcium channel entry. Okay. And second thing, the regulation of membrane potential. Myocyte maintain the relatively higher inter-electronegativity, maintains the hyperpolarized membrane potential at the smooth muscle relaxation. If you maintain the membrane in the hyperpolarization, that is the interior electronegativity, then it will be prevent the maintain the smooth muscles in relaxation phase. Okay, numerous ion gated channels like sodium channel, calcium channel, potassium channel, large conductors voltage and calcium activated potassium channel. This DKCA channel is abundantly expressed in the myometrium. That is the play a dual promoting and opposing role in the maintain the balance between the uterine question and contractility. If you how this maintain the electronegativity, if you open the BKCA channel, that will allow the potassium to leave the cell to maintain interior electronegativity. If the interior of the cell maintain electronegativity, that will prevent the voltage gated calcium channel influx and contraction. So opening of BKCA channel allow the potassium to leave the cell to maintain the interior electronegativity, that will preventing the voltage gated calcium influx and contraction. Same thing, if you inhibit the BKCA channel, that will augment the myometrial contraction by opposite action. Okay, these are the myometrial gap junction. This between the communication establishment myometrial gap junction. electrical through this gap junction, that is electrical or ionic coupling current as well as metabolic coupling pass through the other cells, the surrounding cell. The connection family are floating from cell type specific gap junction. Connection 43 is expressed in the myometer and concentration rise near labor onset. 6 connections subunit form a connection. 2 adjacent connection establish a conduit between the communicating cell. This permit exchange of small molecules that can be nutrient, waste, metabolite, second messenger or iron. What happened? Progesterone promote uterine quiescence in part by lowering the expression of the, how progesterone maintain the uterine quiescence? By lowering the expression of the contraction associated protein like CAPS, maintain the expression of anticontractile agent caspase 3. The progesterone maintain the lower uterus 4 to 6 weeks of the gestational age. This was first described by the Hager, so it is called as Hager sign, subtending of the cervix. Cervical connective tissue. Then recent INICD May 2025 Obstetrics Gynecology questions record. The first question is according to MTP Act. Like according to MTP Act 2023, the opinions of 2 doctors needed for MTP at what period of gestation? Because you know, if there will be the answer basically is very simple. If you there will be a less than 20 weeks gestational age. If you divide the gestational age, if it is less than 20 weeks, then there will be 1 doctor's opinion is needed. And if there will be the gestational age, very simple, if it is 20 to 24 weeks, then there will be a 2 doctors opinion is required. Okay. So answer will be 2 doctors is needed between 20 to 24 weeks. The second question is the minimum age for MTP. The minimum age for MTP is 16 year, 18 year, or 22 or 24 years. All of you know there is no lower limit of like to get MTP done. But usually if you cross 18 years, if you cross 18 years, because 18 year is you have to voluntarily give consent for anything. So voluntary consent can be given because she will be the legal guardian. So woman is legal guardian of herself. So basically if there is no mention, so 18 years is the answer of this choice. Okay. The third question of this OB-GYN course is according to modified rotatum criteria, which of the following criteria is for the PCOS? You know the modified rotatum criteria, the hirsutism, delayed menstruation, these are the 2 criteria. Obesity is not included in the criteria and insulin resistance also not included in the criteria. You know there is a 3 possibility, that is a hyperandrogenism, biochemicals, that is answer is that is a 3 is hirsutism and irregular cycles or delayed menstruations and the ovarian volume. Okay, ovarian volumes is more than 10 cc or any 2 out of 3 criteria, ovarian more than 2 cc or antral follicle count, number of antral follicle count is more than 20 follicle number for ovary. This is the criteria, this is the rotogram criteria. So modified rotogram is basically telling this, there will be a biochemical hyperandrogenism, hirsutism and irregular cycles, and ovarian volume should be more than 10 cc, and if you calculate the volume more than 10 cc and the number of follicles is either more than 12 number of follicles, or if you cross sections 20 follicle number per ovary is the answers. So here obesity is not included in that criteria, but obesity usually is associated with the PCOS and insulin resistance usually associated, so don't confuse. So answer will be 2 and 3. So here is the option is C. The next question, so which of the following does not cause fetal bradycardia? The question is which doesn't cause. So actually usually in the abruptions of the placenta, in abruptions case there will be a early delay, there will be a pathological CTG. You get pathological CTG because there will be a sudden abruption will cause sudden fetal bradycardia. So this is the cause, because you know there will be sudden separation of the placenta, from the surface. So there will be a sudden cut off of the blood from the fetus to maternal. So there will be a fetal bradycardia. And the second is fetal head compression. You always know there will be a deceleration, early deceleration because of head compression during the second stage of labor. Early deceleration will be there. So that will be not the case. Then meconium aspiration syndrome. If the baby is in the distress, there will be some chances of decelerations or fetal bradycardia also happen. But usually the maternal fever, if the maternal pulse rate is increased, because you know every 10 beats pulse rates increase, there will be fever also. That will cause fetal tachycardia also. That will not cause fetal bradycardia. So answer will be D.